Ready, sir.
Good afternoon, ladies and gentlemen. I'm Aishwarya, your host, and I would like to render you all a very warm welcome to AIOC2021. Without any further ado, let's get started with the session. I would request the chairperson to unmute and switch on the camera, starting with Dr. Naren Shetty. Over to you, sir.
All right. Fantastic. Thank you so much. So good afternoon, everyone. I hope you're all having a fantastic day. Today in this session, we're going to update you with the latest and the best in technique and technology in the field of cataract surgery. I'm Dr. Naren Shetty, and being a cataract and refractive surgeon, one of the most common thing I keep doing on a daily basis is trying to find the perfect IOL. So let's look at the new Iol formulas to do so. Can everyone see my presentation?
Yes, sir.
Fantastic. So when we look at the evolution of formulas, there has been 4 generations of Iol formulas, and now we are in the generation of the new Iol formulas. Whenever the word new Iol formula comes into picture, there are a series of questions which come into our head. First and foremost is what's wrong with the old formulas? When we use the the older Iol formulas, in terms of achieving plus or minus 0.5, the percentage is about 71 to 80%, which is kind of acceptable. But when we use the newer formulas, we can achieve plus or minus 0.5, 93% of the time, which is whenever we do or whenever it's easily achievable, you should not settle down for something that is just acceptable. Like Benjamin Franklin said, if better is possible, then good is not enough. This is one of the most used chart where you have the different formulas and which size of the eye suits it the best is given. But when we look at the Iol formulas, we have different categories where we have the ray tracing one, we have the artificial intelligent one, we have the multiple variable one, and the combined one. Let's look at the ray tracing one. The Olsen C, basically, you can predict the effective lens position using the C constant. A very important factor that needs to be fed into this formula is the lens thickness. The fake optics, again, is an online software where it uses the Olsen C constant. Not too much of literature, but I've heard it does a pretty good job. The one more retracing formula is Oculix. Its results are comparable to the 3rd generation formulas like the SRK and Hoffer Q. And when we go to the next, which is more interesting, is the artificial intelligent one. The Hill, the first one is the Hill RBF. As you all know, the AI, one of the main thing of AI is it needs a large database. And one of the important thing or good thing about AI-based formulas is as the time goes, the accuracy of the formula keeps improving. The more the data, the better it becomes. Even we have the Clark's neural network, which is again on the regression platform, and it works on AI. And the main and the important one is the multiple variable one, where we have the Holiday 2. This works on 7 variable divergence formula, where we have the axial length, average keratometry, horizontal white to white, refraction, ACD, lens thickness, and age. And now you can access this online, and also one very nice feature, what it does is you can also personalize your IOL constant in the software. Coming to the most important and the most widely used one is the Barrett's Universal 2 formula. This is a version-based formula, and this, no matter what kind of eye you have, it's like one formula which works for all. And we have the Barrett's True K also, which is very useful in post-refractive and toric calculation. One of the most common mistakes what we do when we're trying to enter the values, especially online, is not selecting the right K index. So always look for the machine that you're using and make sure you choose the right K index and then go ahead with the entering of the other values. Coming to the combined type, we have Superladas, where it brings all the formulas into one equation and gives you the appropriate IOL power. Now, if there's one formula which really you need to look forward, which could be the next big thing, is the Keynes formula. This has been doing really well and has almost equal results as Barrett's Universal 2. And in fact, in some instances where there's irregular cornea or keratoconich eyes, it has performed slightly better. Now, the question is, enough of all these formulas. Can you just tell me one formula which works for all? I think we can just simply go ahead with the, right now with the Barrett's Universal 2 formula, no matter what the eye, just simply go ahead with it. Maybe in just, in a few cases where you have irregular corneas or keratoconic eyes, you can also look at Kane formula and compare the two, and then you can select the IOL for that particular patient. So if I have to switch, how do I do it? First, make sure you update your knowledge, attend meetings, CMEs, go for all kind of discussions. Make sure you upgrade your device because the lens thickness measurement is very crucial. Try to adopt optical devices or optical biometers because it is much more accurate than immersion. And always go for the newer formulas. How do you maximize your outcomes? One is to optimize the lens constant that you're using, validate your measurements, do it yourself or be at least a part of your part of the process. Use extra time in counseling the patients and also stay informed about the latest development. So learning is a continuous process, and it should end only when your breath ends. And I would like to end by saying, using the right tool or having the right tool is important, but using it the right way is more important. Now, all of us know how to choose the perfect IOL, but now and then you get these bouncers where the cornea heals very abnormally and you end up with a lot of astigmatism, even though you chose the perfect IOL. So at Narayanithara, we thought, okay, we need to do something to find, pick up these kind of scenarios. And that is why we developed an in-house polarized sensitive OCT to look into this. Now, if you look at the evolution of OCT, it started in the 1996. Then in the 2002, we had the Stratus, and 2006, we had the SD OCT. And 2016, we had the SS OCT. As you can see from bottom to up, the quality of the image kept improving. But we felt that this was not enough. We felt we needed to go the next step. That is why we thought at NN we are going to build custom-made build polarization sensitive OCT so as to pick up the finer details which is getting missed. So if you look at the theoretical model of fibrillar arrangement of the cornea, this is how it looks like. And what is so beautiful about the PSOCT is it perfectly correlates to the arrangement of the fibrillar on the cornea. And also you can also have information about the axis orientation maps. When you compare the PSOCT to a conventional one, the main advantages is that the several materials and the tissues can change the light polarization state, adding an additional contrast channel and providing quantitative information. One of the biggest plus point of PSOCT is when we look at is the pixel resolution. So when you look at the pixel resolution of the conventional OCT, we have about 5 micron meter. But with the PSOCT, we are looking at 1.4 micron meter, which is simply amazing. And this is how we are able to pick up, the small changes in be it the macula, the cornea, whatever tissue you're looking at. You can really pick up these things so that you'll have a larger information and you'll realize what is actually going on. So this is how the PSOCT and the conventional OCT works. And we did a study looking at the corneal healing post-cataract surgery using the PSOCT. So in this study, we looked at 30 eyes. We did the PSOCT topography and biometry at intervals of the preoperatively day 1, 1 month, and 3 months. So if you look at the images, actually, you can clearly see the increased brightness due to the extracellular matrix deposition as a part of the wound healing in acute phase. Then you can also see the corneal remodeling happening due to the alteration in the collagen orientation. Then at 1 month, you can see areas of fibrosis and scar formation and also collagen remodeling. And when you look at the images at the 3 months, the corneal tissue orientation is very similar to the pre-op phase itself. So the cornea is healed. So I'd like to conclude by saying PSOCT can really, pick out these finer details, and it is not just an imaging device. In fact, it tells you a story. For instance, in this situation, it is telling a beautiful story of how the cornea is healing, how the cornea is changing post-surgery. All right. Thank you for your time. So I think I think moving forward, we have stars and superstars giving talks. First in line is Dr. Lucy. Dr. Lucy is one of our star NN, a very skilled surgeon, a very good researcher. She has a very long list of patients who speak highly of her. Today, Dr. Lucy is going to talk about you're going to talk about the macular toric surgery and optimizing its outcome. On to you, Dr. Lucy. Dr. Lucy?
You're muted, Lucy. Unmute yourself.
Give me a minute, please. I'm trying to share my screen.
Sure. You can double click with your mouse, it'll start.
Sorry about that. Is my screen visible?
Yeah, please go ahead. Please go ahead.
Thank you, Dr. Naren, for the kind introduction. I'll be talking about macular toric surgery and how to optimize its outcome. So when we do a toric intraocular lens, we have to select our patients carefully, do a proper calculation, the axis marking. It also involves a proper intraoperative alignment and post-operative assessment. All these steps are very important to get the appropriate outcome. In these process, the errors can occur at any step, including the errors in measurement, execution, and planning. Here, I'll be talking about mainly the execution error, which involves the axis marking. So traditionally, the toric axis marking was done manually, and with time, different techniques like femtosecond laser-assisted marking, various image-guided systems, iris fingerprinting techniques, and aberrometry-based methods have evolved. So in the traditional method, we make the patient sit in upright position to prevent cyclotorsion, because the cyclotortion of the eye from upright to supine position could change from 2 to 4 degrees on average, but can go up to 15 degrees also. There are various options available for this manual marking, and it can be done as a primary step in the OPD, and it can be confirmed in the OT using these reference markers and a reference marking axis circle and the marker level. But here what happens is when you use a marking pen, sometimes this mark gets smudged. It becomes broader than intended. The slit lamp, when used for marking, the beam might not be appropriate. If you put Paracane after the procedure or while cleaning the patient, it gets washed off. And while positioning the patient also, it needs to be in the straight upright position with the chin touching the base and the head resting on the headrest. Sometimes when there is a little head tilt either to the right or left, or you have a little uncooperative patient, these might cause errors in the marking. Now, these marking errors have resulted in reducing the outcome post-operatively. There was a study done where these 4 manual marking methods were evaluated. They used a needle-based marker, a bubble marker, a pendulum marker, and a tonometer marker. And they found that all these manual marking methods deviated slightly in terms to the horizontal reference meridian. And this, as I said, reduces the outcome of our toric IOL. Till now, we had this literature which said that for every degree the lens is rotated off axis, there's a 3.3% loss of effectiveness of the toric power. But a recent analysis says that the total loss of astigmatic correction can occur with as less as 20 degrees of misalignment and with 10 degrees of toric IOL rotation. So that makes it even more important for us to evolve. As our surgeries have evolved, we also need to evolve in terms of getting our accurate outcome. This is how the different imaging systems came into account.
There are various available options like the Kalisto image guided system, the Varion image guided system, OptiWave refractive analysis or ORA, which is an abrometry based system, femtosecond laser marking system, and iris fingerprinting technique. These image guided systems not only help us in the marking the axis, they also guide us in placing the corneal incisions, centration and sizing of the rexus, as well as IOL centration. At our center, we have the Kalisto marking system. So I'll be going a little more in detail about that. This can be paired with IOL Master 700, and there's a Kalisto refractive suite available. They have a Zeiss forum, which has an EQ workplace with which we can micromanage things. So once the image is captured on the IOL Master 700, we need to make sure that we get a good reference image. A good reference image includes that both the limbus superior as well as inferior is very well exposed. The details of the iris and blood vessels are clearly seen, and the image is well centered. Anywhere where there are disturbances in the image, or the lids are covering the limbus portion, or if it is defocused or a decentered image, such images should not be used, not just for the reference marking, but also to get your proper keratometry. If you have a good exposure, your keratometry would also be perfect, and there won't be any exclamation mark talking about the quality of image being bad or anything. So once this image is taken, it goes to the Zeiss forum or their EQ workplace. There, through the LAN network, it can directly be shifted to the microscope. On the microscope, if you go to the patients and click on the document selected over there, you will see this reference image. Now, suppose during the preoperative planning, this reference image was not good. You can call the patient again, or on the day of the surgery, get a good reference image prior to taking the patient to OT. Once you open these images, it gets directly exported to the patient's data. There in the patient preparation, you can add in furthermore details if you want, like confirming the eye, check for the IOL master data, whether the quality of the scan, the IOL power, everything is okay. Prepare your incisions based on the axis that you want to intend, whether you want a temporal incision or move it so a little superior or inferior based on the astigmatism. You can mark your rexus and centration. Once all this is done, you can verify everything in the summary of the patient, and then you just need to click on the start treatment option just before starting the surgery. When you do that, you'll have these markings for the toric. You can have this display on throughout your surgery, or you can just turn it on while putting the IOL. Like you can see here, the 0180 mark, which we had done for reference, is corresponding exactly with the 0180 mark which comes on Kalisto. And in the end, the final marking can be accurate. You can see the 0180, which was marked using a marker pen, is actually not a single degree axis, but it overlaps almost up to extending up to 5 degrees. So now if we have similar marking done for our toric and using only that as the reference mark, we could go 5 degrees here and there as well. So the different studies which were there in the literature say that these image-guided systems reduce the misalignment of toric IOL much more in comparison to manual axis. And they indicate not just the toric alignment, there is a difference in terms of the vector and vector of the post-operative astigmatism or outcome that you receive. So it improves your outcome also in compared to your manual marking method. Now, the femtosecond laser machines have also come up with this toric marking. On the Catalyst system, there is an option of intrastromal marking for axis alignment. You can see here faint marks of the intrastromal axis marking, which is there. The issue with these intrastromal marking is sometimes they might be slightly faint, and suppose the pupil is not very well dilated, it might obstruct your view for the axis placement. So the LensR system also comes with another option where these marking can be done on the capsular rexus itself. A case report which was published regarding the same shows that aligning along the axis mark on the capsular rexus also gives you good outcome with toric. So that is also one of the options, that the toric marking can be done on the anterior capsule also. This iris fingerprinting technique was introduced by Dr. Robert Osher. In this, using the micron imaging system, a good quality digital photograph is taken of the patient, and based on the crypts and pits on the iris, the marking, your reference marking can be done. This has to be done in a fully dilated pupil so that it simulates the condition in the OT also. Abrometry-based methods like ORA and another method like Holo's Intra-Op have also been there for a few years now. On the ORA system, you can get the power as well as access of toric IOL. The advantage is that it gives you the real-time assessment of phakic, aphakic, and pseudophakic refraction. On the Holo's Intra-Op system, of toric IOL can be marked. I'll just take 2 minutes more. In addition to this, there's Zaldivar toric caliper, which is based on eye-trace tracy refraction system. There also a good quality digital imaging. With the use of that, you can do a 3-point marking system where you can mark whatever landmarks you want. And the same image can be used in OT as the reference mark for your axis. In order to optimize outcome with these digital imaging system, it is good to do your surgical planning properly so that the errors in measurements and planning is reduced. You have to get a good reference image to ensure adequate exposure of the limbus, have good focused image. Intraoperative alignment should be proper along the axis, and make sure that the visco wash is done in a proper way so that the immediate postoperative rotation is minimized. And always double check before you close the surgery, before you remove the drape, or maybe before the patient leaves the OR. It can be checked again using the slit lamp system. So to summarize, I would say that markerless toric axis marking system is the need of the hour to give the best outcome for our patient. It uses a good reference mark for accuracy. It gives you real-time assessment. However, these equipments are extremely costly compared to manual marking techniques. In cases of RK cuts or corneal edema, they might interfere with your view. But then as our surgeries are evolving, so we need to evolve with time to give the best for our patients. Thank you.
Excellent. Dr. Lucy, I think one of the most common questions which whenever markerless surgery comes into picture, they keep asking is, how long does it take actually to register?
If you have everything prepared prior to surgery, then on table it would take less than 2 seconds, less than a second. You just have to start treatment and all your display would be available to you. You don't need to depend on anyone to do your toric marking or shifting the patient and everything. So it's just easy. It would take less than 2 seconds or so for the same.
2 seconds is pretty amazing. So let's play a scenario where, okay, the scan has come, has been uploaded to the Kalisto, everything is ready. How often did you see there was a registration failure when you're working on the markerless system?
Registration failure only happens when the reference image is not good. So that would be detected on your microscope data of patients before only. So as soon as before you start your surgery, if you see your list, you will know which cases had good registration and which not. So even prior to starting your surgery, you could rectify that. That also is rare. If everything is taken care of, it would be in less than 0.5 or 1% of patients.
Yeah, fantastic. So personally, since the time you started using these markerless system, did you find any kind of difference in outcome?
Yes.
To interrupt, doctors, can we take the Q&A session at the end of the panel so that we can continue with the next speaker right now?
Yeah, I know. Just one question. Don't worry about it.
No worries.
So I would say, yes, it definitely improves the outcome. If not much change in quantity, at least qualitatively it improves. As we saw, I showed one paper also, it said that the post-operative astigmatism decreases, residual vector decreases. So especially for our trifocals and multifocals, this is something which gives us good quality of vision. Our patients are very happy as compared to the manual marking system that you would see.
Excellent. Okay. Thank you, Dr. Lucy.
Thank you.
I think coming to the next NN star, we have Dr. Aishwarya. Dr. Aishwarya is a cataract surgeon, again, a very skillful hand. But more importantly, she's the person who every cataract surgeon or any surgeon goes to when there's an iatrogenic infection. So today she'll be talking about a premium. Is premium always the best? Aishwarya, please take over.
Thank you for the kind introduction, sir. I'll just share my screen. Okay, so is my screen visible right now?
Yes, please go ahead.
Thank you, sir. So today's topic is premium always the best? And I do not have any financial interest in any of the products or the companies which have been mentioned in this presentation. Today, I'll take you through how we need to hit the target when it comes to the premium IOLs. We have a 9-arrow system, which is basically the biometry, the topography, the retina exam, the OCT, the slit lamp examination. Of course, the chair time for the patient and the mental makeup of the patient who's ready to undergo and do everything to get the emetropia situation in the eyes, the specular microscopy and the occupation of the patient, which demands 6x6 vision all the time, and of course the finances of the patients involved. Having said that, the surgical expertise of the surgeon takes the most important role. But with these 9 arrows, there are times when even these 9 arrows do not help us at all, and there are some fault lines which occur, and let us talk about them. Firstly, I'll take you through the 11-point checklist which we have at NN. Over here, we talk about astigmatism on a pentacam, the IOL master, all the total keratometry, and we decide whether the patient is having astigmatism which is less than 0.75, and then we'll go for a routine and not a toric IOL. Then higher order aberrations which have to be less than 0.5, angle alpha which is less than 0.5. Specular has to be spot on, the retinal evaluation, glaucoma evaluation, and the squint evaluation also has to be spot on. The pupil size creates a big change in the terms of what is the millimeter size, which is 2.5 to 4 millimeter, which helps us to take a very good decision whether to go for a multifocal or trifocal or not. And of course, the prior ocular surgery, which is important for us to know about the ocular surface, any other ocular pathologies which may be there, and the use of contact lenses, which is more than 5 days. If a person is using, then we want to repeat all the scans after taking off the soft contact lenses. And if it is more than 1 month, then we have to talk about the hard and toric lenses, after which we can do all the scans. So this is our personal checklist, which I would have shared today. Let's take you to the patient number 1. Today I have 2 patients. One of them is a 46-year-old lady, a spectacle wearer for 20 years. She's a myope and hypertensive and a known case of hypothyroidism. Patient is having a spherical equivalent of -9, approximately -9 and -6 in the left eye. Patient is getting best corrected vision of 6/8, 6/6. Patient was very particular that patient wanted permanent surgery and wanted to remove glasses, and that's what she had come to us for. We realized that once we were doing all the slit lamp examination, we realized that other than grade 1 nuclear sclerosis in both the eyes and a myopic fundus, there was hardly anything which could be remarkable. At the same time, we subjected her to all the scans. The pentagam in both the eyes looks fairly similar to each other. If you see the astigmatism, it is around 1.7 in the right eye and about 1.5 in the left eye. And coming to the EKR report, the EKR reports also show a very good reason for you to probably go ahead with a multifocal or trifocal. Talking about the eye trace, as I talked about the higher order aberrations over here, it is again falling into the category of 0.311 microns and 0.264 in the left eye, and angle alpha was again with the normal limits of 0.14 and 0.275. So practically till now, you would not say anything and you will not say no to the patient when it comes to a trifocal lens or a multifocal lens. Again, with the specular, if you see, both the speculars are looking fantastically normal, except for probably in this left eye. If you see this particular area in the left corner, in the right corner, in this particular area, this could be this could be because if there was a false impression or the patient moved during the scan, but otherwise, again, it was fairly normal. If you go to the lens star, 900 in both the eyes, axial length is right eye is 27.86 millimeters, and in the left eye it is 27.11 millimeters. Astigmatism in both the eyes look fairly similar. Having this particular instrument, that is lens star 900, has given us this particular insight, and we wanted to compare it with IOL master as well. So let us go to a particular sheet that I've made. So in the axial length in the right eye, if you see in the Iol master is 27.87 and in the lens eye 27.86. Here it is 27.07 and 27.11. Both of them are having very similar anterior chamber depths. If you see, lens thickness is again over here, there is some difference, 3.99 and 4.03, but here again the similar difference is present over here in both the eyes. Coming to the astigmatism, fairly again slight difference of 0.07 over here in the right eye, and in the left eye it is very similar. With all this data, you would still say, why would you not give a multifocal or trifocal? Let's go ahead. Coming to the OCT, OCT showed a routine myopic fundus, which was having some amount of thinning in the retina, but at the same time, again, structural damage or structural changes were not present in both the eyes. The first 3 photographs are for the right eye and the last 3 are for the left eye. Both of them do not show most of any other changes except for being a myopic fundus. Once the calculation was done, with all the values, with the true K values for the Z-Calc or the Zeiss calculator, we found in the right eyes was plus 5.5 with plus 2 astigmatism at 81 degrees. And in the left eye it was coming out to be plus 7 with plus 2.5 at 84 degrees. When the Iol master K values only were taken, the right eye was very similar, but in the left eye, it increased by a diopter to plus 8 with plus 2 astigmatism at 89 degrees. Coming to the Zeiss calculator, if at all we put the pentacam values, the difference was slightly again higher with astigmatism coming down. And when we use the Iol master with the Barrett TK values, we found that the right eye again increased by plus 1 diopter and over here with plus 8.5 diopters. With all these values, the question is, even the doctor is confused what to give because nothing is conforming to what we should be given and what should be the final outcome. We explained this situation to the patient. Patient was very understanding and she understood that it would be probably better to go with a toric IOL, and we implanted plus 6.5 toric with a mysis femto, which is what she wanted, and went ahead and gave her a 6.9 with pinhole 6.8 vision on the first post-operative day. And in the left eye, it was a plus 9 diopter lens, which was implanted with Alcon toric, and 6/8 with pinhole 6/6, and 18 was on there on the first day. So what I would like to say is that similar situations can occur to you every now and then probably taking a decision, an informed decision is very important. This is the original file from which I've showed which all lenses were implanted in both the cases. Now coming to patient number 2. Now, this patient had come in 2019 for a cataract opinion. Patient had undergone a laser procedure elsewhere about 30 years back. Patient did not have any records with the patient, but patient was a known case of hypertension and diabetes, type 2 diabetes, and had undergone angioplasty about 8 years back. Patient was a housewife, was very clear that although the right eye is fine, but in the left eye, she is very clear that she doesn't want any glasses at all costs. We subjected her to all the scannings and we realized that in the cornea, there was 4 RK 90-degree crosscuts which were present, 2 superior and 2 inferior AK with inferior nebular opacification, crocodile shagreen, and central island line deposition. Right eye had grade 1 nuclear sclerosis and left eye had grade 2 nuclear sclerosis PSC. And in the left eye, myopic fundus along with no evidence of diabetic retinopathy was present. This is how the right eye and the left eye looked. If you can see the left eye scars over here, pretty prominent. These are the crosscut scars and the AK scars which are present with the iron line deposition which is present over here. Astigmatism was around 0.6 in the right eye and the left eye was 7.9. See the difference between K1, K2, 32 and 40 degrees over here, diopters over here. And the steepening was around plus 84 microns over here in the left eye and the elevation front. A patient's Bellin-Ambrosius scan ectasia was around 3.85, D value was 3.85, which was very high for the left eye. And in the left eye again, if you see how the EKR has started from 1.85 at 1 millimeter zone and increased up to 2.15, and it was fairly distributed from around 25 to around 45 diopters over here in the actual zone. So this is how the left eye presented, and with all these scans, we did more and more scans. Even in OP scan, we found that the pupil diameter was around 2.76, but in the right eye, but in the left eye, the coma order was very much increased. And along with all these scans, we realized that our anterior segment OCT showed that almost 90% of the cornea was cut with these marks which had been made as RK cuts about 30 years back. With this data at hand, we could not help but suspect that there was a component of amblyopia in this particular eye, given the fact that the axial length was actually very much increased, and that was around 26.82 as compared to 23.81 in the right eye. One important thing which I would like to suggest over here is that with prior RK, whenever we are doing any of the IOL calculations, the target refraction has to not to be put over here as 0. It has to go to around -1, or in fact, there are times when doctors take it as -2 as well, so that you can get a better value and a better reading in the postoperative period. If you see with -1 target refraction, we got a maximum of 24 diopters. And with this is eventually what we did, that we implanted a IOL power of 24 SN60WF in the bag. And after 4 weeks from CF2 meter, which was there earlier, the vision was CF3 meters improving to 6/36, which was the eventual BCVA also. And the refraction was around plus 2.25 with minus 5.5 cylinder at 90 degrees with plus 2.5 add. With these values, I would like to say that no matter what, whenever we are having a premium IOL patient, we have to see all the values. We have to agree to all the criteria and then get a fantastic result if everything is in place. The preoperative, intraoperative, and postoperative care for such patients is extremely important, because at every step they have to be explained why are we doing this. If we fail in doing so, then the patient becomes a little apprehensive and a little agitated. They don't understand why we are doing so many tests. We have to also set the expectations right. Most of the patients have faith in you. They know that what you're doing is correct, provided that you give them ample time to explain what you're doing. We have to discuss the pros and cons. You need to have your consent form ready, with which you have to explain the patient and also discuss what can happen if this goes wrong, or what is the eventual outcome that you're looking forward to. There are times when the IOL delivery takes time. The IOL delivery may not happen on time, especially during these times. And you also have to explain what IOL you're going to be using for the second eye surgery as well, because these are premium patients. They need premium care and they need to understand what are they heading towards. Teamwork always wins. At NN, we are very, very fortunate to have a huge team, which not only takes care of the clinical part, the calculation part, the part where we have to explain to the patients, the counselors, the team, everybody. And we have to keep this room for error, because this room for error is something they have to explain to the patient. There are times when high myopes may not end up at 6/6. This particular line has to be explained to them. And of course, the insurance aspect, because not all high-end lenses are covered under insurance. Having said this, I think I end my presentation today. And I'm really thankful to all of you for helping me out for this particular presentation. Thanks a lot.
That's great. Perfect. Just a quick question, Dr. Aishwarya. I mean, let's play a scenario where monofocal patient is, one eye monofocal is done and patients come to you. What would you do for the other eye? Do you give an option for a trifocal also, or you just simply go ahead with a monofocal?
So in that scenario, there are many surgeons who do that. They want to, they give them their option, but at NN, we don't do this, because it is better that the patient neuro adapts to both the lenses. It is better to have both, let's say, toric in both the eyes or multifocals in both the eyes if it is possible, and the patient neuro adapts better.
Right. So what about, let's say, if a dry eye, you have done your test and the patient has dry eyes, do you say completely no to him for a trifocal IOL?
No, not completely no, sir, but it would be better that first of all, we explain the patient about the condition of dry eye, explain at what extent the dry eye is present, treat the dry eye first, and let them come back after a month or two, and after the whole workup has been done and all the treatment has been given, and then subject them to the scans again, and then show them the difference, and then go ahead for it if the dry eye has been treated over there, and then go for the premiums.
Good. Excellent. Thank you, Dr. Aishwarya. I think, coming to the next star, actually, he's not a star, he's a superstar. It's really my honor to introduce Dr. Himamshu. If you want to find a perfect surgeon, perfect teacher, and more importantly, the perfect human being, you need not look further. I myself have seen him personally helping patients walk into the OPD. I mean, he doesn't need to do it actually, because we have a lot of staff who's doing the same job. But that shows the passion he has towards the patients. Dr. Himanshu has been actually a very important pillar of Narang Netralaya. Blessed to have him as my mentor. Today, he'll be talking about managing baby boomers. Dr. Himanshu, please, on to you, sir. So you're muted, sir. Please unmute yourself.
Okay. Thank you, Naren. It's really pleasure to be with you, and so nice of you to speak such good words about me. I'm really overwhelmed. So the topic to me is post-refractive surgery. Baby, I mean, I had to decipher what exactly, and I asked Lucy that what exactly you want me to speak. She said, like, I want you to speak on the post-refractive surgery IOL power calculation. So basically, all of us are going to come across such kind of scenario, and we already have come across, but we are going to come across more and more such scenario where people will come across to you who have undergone refractive surgery in past, and now we have to deal with them with their expectation and their IOL power calculation. Now, earlier, whenever we had a post-LASIK refractive surgery patient or post-RK patient or post-PRK patient, we knew that the relationship between anterior surface and posterior surface is deranged in cases where you flatten the anterior surface, like case of LASIK or PRK, whereas in RK, the relationship between anterior and posterior surface is still maintained. But the cases where the anterior surface relationship is altered, like in LASIK, what happens is that when we measure the keratometric values are falsely overestimated, because the measurement is done somewhere around 3.2 to 3.5 millimeter in a zone, whereas the center part of the cornea does not follow the same suit or same curvature as it is there in that region. And hence we ended up having the hyperopic refractive error. And so many formulas. And earlier, I remember I used to sit and calculate all these things on different formula. But now, thankfully, we do not need to do such kind of thing, because we have now ACRS calculator. Now, I'm not going to go into theoretical detail of any of such kind of thing, and you all know that how we calculate these things, but I'm just going to give you practical example. What if some patient comes to you, and what if something which you have or something which you do not have? Let's take one example. A person who has undergone surgery long back and in right eye has come back with a cataract, a significant amount of cataract, which has led to refractive change, mainly due to the cataract surgery now. I mean, cataract there in the eyes now. Now, look at the scenarios. Now, what if one of the center has IOL master and has OpScan, and they are going to use it for the ACRS calculator, or the other center has LensStar and Pentacam, and they are going to do the same thing? What happens if we have such kind of different scenario? Let's take center one, which has the IOL master and OpScan combination. The combination can be anything. I've just taken the example here. Now, when we taken the IOL master, you also have to pay attention to the N values, which is set for the machine. And here it's 1.332, remember that, because that's going to change the IOL power calculation. So let's see the data which we have from the IOL power, as well as the data on OpScan. We put the pointer in the center part and we get the central axial power from there. Now let's calculate in the ACRS calculator. Now remember, in ACRS calculator, many things may not be there. There is no OpScan data available for the central corneal power there. Doesn't matter. If there is something else which is not available for one particular machine, doesn't matter. If the principle is similar, you can actually utilize that. Now let's see if we put the data from the keratometric data from the IOL master, which is standard and which is absolutely fine. But the place where we have to put our IOL master data, the central power, is where the Galilei part has been given. Now, the true corneal power of or total corneal power in the Galilei, where we have not used Galilei machine, but in fact, instead of that, we can put this data in that place. After that, we pay attention to the K values, as I told you that we have to adjust it here because in the machine of Iol Master, it has been 1.332 as a setting. So let's do that and then go ahead and calculate. The lens power which you get averaging different formula, usually would like to take with the average as well as the minimum power what you get there. So we got somewhere around 90. Now, what if the patient had gone to other center? Now you have Iol, instead of Iol Master, you have Lens Star there. And instead of the topography like OpScan, you have now Pentacam. Now Pentacam has other calculation. The reason behind taking Pentacam because we will be able to calculate many other things like in equivalent K reading or EKR map of Holiday. We can have zonal K readings from like 1 millimeter, 2 millimeter, 3 millimeter, 4 and beyond that. So what we can do here is that we can take the reading from the center part as the central K reading, and again it's equivalent K reading, so which is like almost a true corneal power what we measure, and which is normally taken. So let's fill in the data into this thing. Now here, instead of Atlas, where it's a Placidos based topographer, we take the value from the EKR values of 1 millimeter, 2 millimeter, 3 millimeter. We enter those values there. Again, in IC system, where effective corneal power, whatever we have, in that we add the power of the center power there, or rather 4.5 millimeter power from there, and the center power we add into the 0 millimeter zone. So what happens now here is the instruments are different, but the values we are utilizing there. Now from the Lens Star, the values are standard, but again, remember that we have to pay attention to the K values or index, whatever we are taking, and we change the index to 1.337 and then go ahead and calculate. Well, what we get is similar power. Now think about it, two different places, two different sets of instrument, but we got similar power and the outcome was excellent. Now what if the place, instead of this thing in this place, if we had just gone ahead with the Iol Master or Lens Star directly, well, we would have certainly end up a significant amount of hyperopia. What if we didn't have topography at all and we just had the optical biometers? Then if we calculate the lens power, well, with the Iol Master, with whatever we decided and see, we have not put any other data anywhere. And if we just calculate, it still gave us the same power. And if we use the Lens Star in some other setting and follow the same suit, and we realize that we got similar power here. So irrespective whatever formula we use, or irrespective rather whatever machines we use, if we know that it's done properly, we still can do quite well. I'll take second example now. The LASIK was done, but we have post LASIK data available with us, so that we know that what we can utilize some other methods like historical method and those things. Now in post LASIK data, we realized that patient had cylindrical power, and now patient requires toric IOL. If you look at the data which we saw earlier, along with the topography data, the topography also showed cylindrical power, which was matching. And now if we enter the data into the ACRS calculator, similar to what we did, the total corneal power earlier we measured, we use the data from the keratometry, as well as the data, which is the historical data, what we enter here. And then if we calculate, we get a power somewhere around 9.5. Now, if this power, if we use and utilize the toric calculator, and in the toric calculator, we put that as a spherical power. Using the toric calculator, the lens power, whatever we got, and we got the significant visual outcome. So what if we didn't put any of these data like keratometric data or the topographic data? So that means we only have history as well as the keratometry value with us. And if we calculate, we still got similar power. So what do we get from this thing? Regardless of the method you employ, if you have good biometer with us, and if we are using ACRS calculator, we surely can hit the target most of the time. And especially whenever such kind of cases require premium IOL like toric IOL, multifocal IOLs, that's where your spherical outcome would be very, very important. With this thing, I would like to thank Dr. Varun Kharbanda for his profuse help for making this presentation. Thank you.
Excellent talk as usual, sir. Just a few questions, sir. One is, if a post-refractive patient comes to you, and do you still give an option of a trifocal IOL for such patients?
I would certainly give an option of trifocal IOL. So the thing is, the problem with us not giving such kind of option earlier was we were not sure about the emmetropia which we will hit. Now, as earlier Aishwarya was talking about that we'll target -1, -2. Now, if you think about, if you are not sure about the emmetropic outcome, if patient is left behind with spherical error of -1, -2, even if we give trifocal or bifocal or anything, it's not going to help us. But with all these things, whatever now we have realized that post-refractive surgery IOL power calculation has become much accurate, and we are able to hit emmetropia most of the time, if not always. So in such kind of scenario, I feel quite encouraged to offer them trifocal lens. In worst case, if at all I miss my target, I wouldn't mind going ahead and doing a touch-up with the laser and remove that power. But I certainly would offer them a premium IOL post-refractive surgery, provided surface is regular.
Fantastic. So one more question is, let's say, since you touched the surface is regular, let's say if at all you do have these kind of irregular corneas coming to you, would you do like a topo-guided treatment like before or after surgery? What is your preference?
I would love to touch such cornea pre-operatively. Again, you showed earlier, I've seen your presentation, you showed very nicely that even post-operatively you can touch them and they do very well. And you'd also shown earlier that you can touch pre-operatively and do very well. Personally, I totally agree that we must regularize the surface. So it helps me in spherical, cylindrical, both ways. And then I go ahead and plan my premium IOL. So irregular surface, if I can regularize it using topo-guided surface treatment, I would be really keen to do that.
Completely second that, sir. Thank you so much, sir, for your talk and time. All right, coming to the next star, we have Dr. Chaitra, again, a very skilled surgeon. All the patients love her. Actually, not just patients, extremely popular among the staff. Every doctor actually fear her, including the MS. If any mistakes in the document, you have to answer to her. I think jokes apart, she's a wonderful human being, very quietly helping a lot of staff and patients financially and emotionally in this COVID time. So today she'll be talking about neuroadaptation. Is it a myth or mystery? Dr. Chaitra, the screen's all yours.
Thank you for the kind words, sir. Good afternoon, everyone. So my topic is neuroadaptation. Neuroadaptation has emerged as a hot topic for cataract and refractive surgeons as we observe patients challenged by presbyopia correcting lenses. While many patients adapt quickly and successfully to these lenses, some adapt very slowly or not at all.
The first click should be with the mouse. The first click. Rest you can press arrows. You can press the arrow here. Yeah.
Yes, thank you. So modern lens surgery aims to accomplish ambitious goals in visual and refractive outcomes. So addressing pseudophakic presbyopia is an important topic in the practice of modern cataract surgery, specifically in refractive lens exchange. So one of the main treatment modalities of pseudophakic presbyopia are the multifocal lenses. And the main challenge for multifocal lenses is that they use a non-physiological optical method to improve near vision. By definition, multifocal lenses separate light into different foci, and this causes a dispersion of the energy of the light entering into the eye. So this results in a change in the physiology of vision as the light follows a different focal performance at the level of visual axis and consecutively at the level of retina. So it is necessary for our brain to activate a process of neuroadaptation the capability of the brain to adapt to changes, to adjust to the neurophysiology of the changes that are induced by the quality of the retinal image by the dispersion of light due to the multifocal lens. So with multifocal lens, like I was saying, a focal multiplicity is introduced to the visual system long before the sixth order, and this presents the visual cortex with an unprecedented challenge. Our established neural circuits are not wired to process a monocular image that is partially focused and defocused. So our eye works in such a way that it processes only one image, that is one image at a time monocularly. So the division of light caused by the multifocal lens induces different focal points. Thus, the brain receives simultaneously different images which has to be processed and used to focus objects. This is the reason that a visual neuroadaptation process is necessary for the brain to process the different images which are provided by multifocal optics. Failure in this will lead to the perception of glare, confusion, distortion, and the feeling of poor vision postoperatively. So neuroadaptation is believed to play an important role in determining favorable outcomes after multifocal lenses, especially with regard to positive dysphotopsias like glare, halos, and starbursts. So neuroplasticity refers to the ability of the brain to reorganize its function and structure in response to changes in the environment. So in case of multifocal lenses, it is actually a process in which the brain basically learns how to rectify the image to promptly use it so that the final perception is as real as possible. So it is important for the surgeon to take time to discuss this before the surgery, as a patient should know that sometimes it takes time to achieve good vision. Visual neuroadaptation in multifocal lenses is more difficult and may be time consuming, and it is dependent on individual factors, dependent on the type of the lens that was used, on the higher aberrations that are produced by the lens, and also on the individual patient itself. So one of the variables is age. Younger patients adapt quickly than older ones. So another thing highlighted by the adaptation problem associated with multifocal lenses is the reality that our visual system has two distinct components: the optical system that alters light before it reaches the retina, and the neurological system which processes this information. Sometimes neuroadaptation is very fast, like how we adapt to light or dark, but some types of adaptation happen very slowly over weeks or months. So the slow adaptation results from neural plasticity, which, like I was saying, is an alteration in the anatomical connections or synaptic properties due to neuronal activity. So this study by Rosa et al. Used functional MRI to evaluate the association between dysphotopsia and neural responses in visual and higher level brain regions. They stated that in patients with who had multifocal lenses implanted recently, had increased activity of cortical areas dedicated to visual attention and effortful action, which is represented by frontoparietal circuits. Increased activity was also seen in the cingulate cortex, which was responsible for procedural learning and cognitive control. And increased activity is also seen in the caudate nucleus, which is responsible for goal-oriented behavior. And patients who are bothered by visual symptoms showed even more increased activities in these areas. And such effects were not present in age and gender-matched control group of healthy participants. Hence, they represent the initial phase of neuroadaptation. Moving on to the management of these patients, cognitive training stimuli seems to be the most effective method for the enhancement of neuroplasticity in elderly subjects. The benefit is in terms of visual performance as well as in terms of less perception of photic phenomena. So some authors propose that neuroadaptation can be hastened by visual training. However, there is no consistent evidence. Although some evidence indicates that visual training might be a possible solution for the non-adapting patients. The development of strategies that facilitate the neuroadaptation process to multifocality might be an effective strategy to reduce patients' dissatisfaction. So these studies highlight the physiological potential of video games, gamer patches, and orientation discrimination to improve as a perceptual strategy to improve visual acuity and contrast sensitivity and thus promote neuroplasticity. Visual performance after multifocal IOL implantation significantly accelerated with exercises using Gabor patches or orientation discrimination. This is a pictorial representation of Gabor patches, which are stimuli that drive early visual acuity in a controlled fashion. They are a series of black and white bars which can be oriented in any which way. So 2 to 3 weeks of training or 2 to 3 months of training also in certain studies have seen a significant acceleration in the visual performance. So multifocal IOL explantation and exchange should only be performed when there is no other alternative and all the causes leading to patient dissatisfaction have been properly ruled out. There is a lack of effective treatment for these complaints, leading to 4 to 12% of the cases going in for IOL explantation. This has, however, remained a drawback to the more widespread use of multifocal lenses. I would like to conclude by stating that the typical neuroadaptation process after multifocal lens implantation involves a minimum of 3 months to 1 year after surgery for the phenomenon to significantly improve. In summary, however, the preoperative combination of appropriate patient selection and accurate lens selection results in a good judgment and correct indication of multifocal lenses, leading to a satisfied patient. Thank you.
Excellent. Good. Great presentation, Dr. Chaitra. So I think just to ask you again, the million-dollar question is, before surgery, will you be able to identify a person who will, mostly have a delayed neuroadaptation or won't have, or he'll be very, even with the perfect surgery, perfect everything, he'll still be, having a lot of complaints. Do you have any suggestions or clues on how to identify these kind of people?
Like you already said, yes, neuroadaptation is something you cannot predict. But yes, careful, like Dr. Aishwarya is saying, a good chair time with patients. If we assess the patient's needs, their lifestyle, their psychological profile, and select the accurate IOL for them, maybe we'll have better results, a better clinical judgment will give us a happier patient post-operatively. But there's no way to predict how fast or if the patient will neuroadapt or how late will it be.
And do you have any tips for faster recovery or faster neuroadaptation?
There are some studies, like I was mentioning, visual training helps in neuroadaptation. However, I think larger studies will be required to indicate its clinical significance, training with Gabor's patches and orientation discrimination. But there are no good studies. Maybe we'll have to conduct some studies and see how the performance will be.
Actually, very true. I feel one of the key for faster recovery would be the acceptance. So if the patient really accepts the fact, okay, this is what the vision will be, and these are the side effects, I feel their adaptation will be very quick. So that is why preoperative, like you mentioned, counseling is very crucial. He has to have a more realistic expectations. I think after that, the adaptation just happens instantaneously. All right, fantastic. Thank you, Dr. Chaitra. Okay, coming to the next NN-star, we have Dr. Pooja. She's a very good cataract refractive surgeon, and research is built into her genes itself. And she's always a yes person, and once a work is given, she'll make sure that it's done and she will give her best. Today, she'll be talking about a few X-files. Dr. Pooja, please.
Thank you, sir. Thank you, sir. That was a very kind introduction. So I would be talking about 2 case scenarios from which we can learn a lot and take back home the points which we can apply in our clinics. So Himanshu sir has already spoken about the IOL power calculation post-refractive surgery. I'll not go into depth of it, but there are a lot of times which he spoke about that patients might come to us saying that, post-refractive surgery, they have been seeing starburst persistently. And we have one of the patients who had undergone PRK surgery 20 years back. And since 20 years, she's complaining that she's seeing the starburst persistently. And now she's come back to us, and she's developed cataract. She has NS2 grade cataract. So the challenge was, should we go ahead and do a cataract surgery for her directly, or just because she has a complaint of starburst right after surgery for almost 20 years. And here we can see that she has a little bit of descended ablation. Should we regularize the zone and then go ahead with the surgery? Because if we just do a cataract surgery, post-refractive surgery, her the quality of vision might be poor. So like the vision is responsible, there is an optical axis and the visual axis. The decentration is labeled when the ablation is eccentric, which doesn't correspond to the center of the optical axis. And the small zone will correspond. If your mesopic pupil is less than your optical zone by around 1.1 millimeters, then also it is called small zone. In either of these conditions, then your patients or the patient has a highly aberrated cornea, or the comas are higher on your cornea, more than 0.5, or spherical aberration of more than 0.5, or the patient has descended ablation. If we go ahead and do a cataract surgery, the post-op quality of vision is going to be poor. You've cleared the lens, you've done the beautiful cataract surgery, but if you have not taken care of the cornea, then post-cataract surgery, you will have the patients will have a poor quality of vision. So the challenges to be tackled in this case were, first of all, the patient had a descended ablation and a highly aberrated cornea, and the second would be choosing the right formula. I will not touch upon it because Himanshu sir has already spoken about it. So now, if I just said, if I do a cataract surgery, then post-operatively there'll be inaccurate and unpredictable outcomes, refractive surprises, there can be delayed epithelial remodeling, which will again cause poor visual quality. Patient will require an additional layer procedure, because of which patient can land up into a refractive surprise. When we are trying to regularize the surface, he or she can land up into a refractive surprise. For that, we might need an additional procedure or a circoflex lens to correct that refractive error. And when we do multiple procedures on your cornea, like the wound healing response changes, there's a lot of changes going on your ocular surface, and the patient will have excessive dry eye to begin with. So the second option which we have is, if we do a corneal customization, if we regularize the cornea and then go ahead and do a cataract surgery, we'll have a predictable eye power calculation, and the post-refractive surgery visual quality will also be better. So we have just made this bromogram which deals with decentration, evaluation, and applying for laser correction, where we first do the after ocular surface examination, we do a topography and aberrations. If the topography is well centered with minimal aberrations on cornea and a good EKR map, we go ahead and do a cataract surgery. But if there's a decentration, or if it's a small zone, or if your cornea is extremely aberrated, then or the EKR is a broad base, the EKR is not a good map, and there's a lot of jumping of the EKR 65K values and the astigmatism, then probably we would like to regularize the cornea. This is for a premium eye surgery and for better quality of vision. So how do we proceed? We do a contact lens trial. It would be an RGP lens. If the visual quality improves, that means, forget the cataract part, but just the corneal aberration part improves. That means the higher the corneal, you're dealing with a cornea problem or cornea aberrations, and then you will go ahead and first do a corneal customization. After that, you will do a cataract surgery. If your condition is not improving, it means that post regularization also, contact lens, post laser regularization also, the vision might not improve. So our approach would be a stepwise approach. There are different machines on which you can do the regularization. This is just a flow chart of how you can do it on wavelight machine. No financial interest here. First, you bring the Q value to 0. Q value will lead to an induction of SA. Then there is a C4, C12 compensation, which you compensate for it. And once you have compensated for that, if you are planning a sequential procedure of laser-based procedure after cataract, you can do just a C4, C12 compensation, and you don't correct any refractive error and consider that for treatment. And this is just a simple flow chart on, you first export the good quality scans from Topolizer to a wavelight platform. You set the refraction to 0 and check for C4, C12 value. You compensate for C4, C12 value by adding myopia when your Q value is normal. You balance the difference of the hyperepic and myopic ablation, and then you consider for the treatment. And if you have a Schwind platform also, the plan would be the same. You would plan it on a PRK platform. You check the quality of scans. You set the refraction to 0. You minimize the aberrations by choosing the depth minimization problem. So you can just correct the aberrations which are needed to be corrected or which are on the higher side, and you don't correct the other aberrations. And then you choose the minimum power with alteration in the optical zone. Here you basically need a larger optical zone where you will increase it to 6.5 and then do a correction. So after we've done a corneal customization, you cannot directly go ahead and do a cataract surgery. So when you go ahead and do a cataract surgery, you will wait for at least 2 topography scans which are stable over 4 weeks, or at least 3 months after your laser surgery, and then you go ahead and operate for a cataract surgery. And also you would like to see whether your EKR, if you want to do a premium IOL, you have to check for the EKR map and how your corneal aberrations are and how the astigmatism of the cornea is on the EKR 65 map, if it's regular or not. And if it's a broad base, probably you would like to avoid a premium IOL, but if it's a peaked on a shorter base, you can probably go ahead and do a premium IOL in this patient. So you will do a premium IOL taking care that all of this are within normal limits. This is just the example of the patient that post TCAT cornea, how the cornea improved, but still there was cataract. So we operated the patient for cataract. We chose a +8 dioptric non-toric monofocal lens. And this is the result of post TCAT. The overall ocular condition had improved, and this is after the cataract surgery. So the idea here is whenever your patient has a decentered cornea or a decentered ablation or a small zone or a highly aberrated cornea, first you would regularize the cornea and then go ahead with the cataract surgery to have optimal outcomes, which IOL power and IOL calculation to choose. Himanshu sir has already spoken about it, so I'll just skip it. Whether MFIOL multifocal lenses post myopic classic are possible or not, yes, they are possible. But first of all, you need a extremely motivated patient with realistic expectations. Your angle alpha should be within normal limits, which would be less than 0.5. Your corneal aberrations also should be within normal limits. Your ocular surface, which is very healthy, should be within normal limits, and your cornea should be regular. It should be like a well-centered ablation and a good peaked EKR map. Then only you would choose to go ahead with a multifocal lens. Otherwise, if patient has any contraindication or any one factor which is not falling in place, you would probably avoid a multifocal lens and you would put in a monofocal lens for this patient. And the most important part when you're dealing with this is you have to explain the patient everything in detail about the laser procedure and what you're going to do, because whenever you do a laser procedure, you might induce some amount of refractive error, but you just have to explain the patient that will be taken care of while you're doing a cataract surgery. So no need to panic. And a very tight consent, a detailed consent is very, very, very important for these patients. And post-op management, you would keep them on a steroid for a longer time. And if you've done a lot of laser multiple times, you would probably add cyclosporin for this patient and high viscosity lubricating agents for a longer time. So can I go ahead with the second case or?
Go ahead. We have a lot of time. Go ahead. Yeah,
so this was about the like how you would choose if you would do a premium IOL post LASIK surgery or not, and how you would go about it. My second case is going to be about importance of epithelium. It's more of 2 different cases, and importance of epithelium in our practice. So whenever you're planning a premium IOL, you obviously would do a topography and you would see if everything is normal, your ocular surface and everything is normal. So this is one scenario where there are 2 patients with normal topography. Based on chatometry values and your lens star or your IOL master, you would go ahead and choose the IOL power and do a cataract surgery. You would expect a good outcome, but here patient 1 has good quality of vision, but the patient 2 landed up in a poor quality of vision. Now, why did happen? Everything was normal, your topography, your IOL power calculation, everything was normal. But then why did this happen? So we've just went ahead, like, what we are looking at right now is when you do a keratometry and a corneal topography, the aberrations which you're looking at are just the cornea, for the cornea total. But we have to now realize that now we have moved one step further where we are dealing with epithelial irregularities also, and the aberrations can come from epithelium as well. So if you see here, if it's normal epithelium, then post-operative, the epithelial aberrations will be like within normal limits. But if there is any epithelial irregularity present here, if you can see the center is around 55, the periphery is 60. And if you see the epithelial the refractive error of just the epithelium, it is plus 0.06 with minus 0.83, and a lot of aberrations present here. So And we did a cataract surgery on this patient, and that's why post-operatively, the patient who had a normal epithelium landed up having a good wound healing and a good epithelium. But irregular epithelium patient, when we did a cataract surgery, it might land up into a lot of epithelial irregularities or epithelial hyperplasia, and that might induce more power which you were not expecting. So the refractive surprise and the poor quality of vision which you have got is not because of your IOL power calculation or something where you've gone wrong in your evaluation. It is just because that there is a lot of epithelial changes present which are a sign of ocular surface disorder, and that is why it has happened. Just a poor ocular surface, unhealthy ocular surface will have an irregular epithelium, which will lead to a post-op refractive surprise. So in this kind of patients, you would normally avoid a premium IOL and not use not go ahead with any toric IOLs or any multifocals IOL. First, you would like to treat the surface and then take the patient up for surgery. So how do you treat the patient? There are a lot of possibilities available. You can you cannot wait along. So you start the patient on doxycycline for 4 weeks. You give them tapering steroids, low dose tapering steroids for tapering over 4 weeks. You give them sodium hyaluronate based eye drops, cyclosporin 0.05% eye drops for 4 weeks. If you see that the ocular surface issues are on the higher side, you would probably do a modern day dry eye therapy for them, wait for 4 to 6 weeks, and then plan a surgery. These cases are like when your pure film metrics, like your Shermer's, T-BUT, and your other values are within normal limits, but still there is an epithelium issue which you cannot make out with your dry eye metrics. This is when you do this protocol, and not for the manifest dry eye patients. Thank you.
Excellent, Dr. Pooja. So, I think now we are in the era where we realize that epithelium is very, very important. Sometimes it might really, falsely say the cornea is irregular or some other issue. But since the time you have started looking more at the epithelium, what kind of, how much percent do you think are the patients who initially you label them as not suitable candidate for trifocal patient and who have come into the suitable value? What percentage?
That is a very good question, sir, and thank you for that. After we have started looking at the epithelium maps and doing the retrospective analysis also, we've seen that around 20% of the patients have around 15 to 20% of the patients have these issues, where we would like to treat them and then do surgery, or probably avoid a trifocal or a multifocal lens for them, sir.
Good. I think 20% is a pretty significant number. So the other thing is, let's say, whenever we just give some numbers, okay, within this, let's say higher aberration within the 0.5 and blah, blah, blah. And so, but what do you do when you get these borderline cases? Because that's what happens, actual scenario where you have 0.57, 58, then what do you do? You're in a fix whether you don't know whether to push the patient for a trifocal or not. So if you're in those kind of a borderline cases where you have even the higher order angle, whatever it is, what lens would you select? Like a trifocal lens or a extended depth focus lens? Do you have any kind of a preference?
Sir, based on our experience and what I've learned from my seniors, I think extended depth of focus lenses would be better for this kind of patients rather than a trifocal or a multifocal lens.
Yeah. I think totally second that. They are a little more forgiving, actually, extended depth, especially in these kind of borderline cases. I mean, if it is too abnormal, please do not go for any kind of trifocal lens. But definitely, I think borderline cases, it's always better to go for these kind of EDOF lenses. All right. If anyone has any comments, suggestions, questions. Fantastic. I think if no one has any questions, I think let's put the session to an end. I would like to thank Isha and
Thank you so much.
Yeah, I would like to thank AIOS for giving this opportunity, and all the speakers for sparing their time. And I thought someone wanted to say something. So really thank all the speakers for sparing their time, and they've given a wonderful talk, a lot of information. I myself learned so many things. Thank you so much. Thank you, everyone.
Thank you so much, everyone, for such an informative session. Have a great day ahead. Thank you once again. Thank you.
Thank you.
Everybody, have a nice day.